So,
welcome everybody. We're kicking off the second season of the Journal Club. We're very happy that you guys are here, and 4 out of 5 of the organizers are here, and I wanted you guys to introduce yourselves and say a few words. So, Eva.
well, I will talk today as well. So as you can see from the presentation, I'm in the last year of medical school, finally. And my main interest is hemodynamics, so interventional cardiology. I guess what I will do after depends on how well the test goes, but we will see. Anyway, cardiology in general is my main interest as of right now.
Okay, Anna.
So, hi. Non so, aspetta.
My name is Hannah. I'm in 6th year as well as Eva for the MD program. My main interest in study is psychiatry, and we will meet in the future, I think in November at the end. And also perhaps in a future meeting we will organize with Prof. Writing regarding the matter mainly of bioethics, talking about predominantly euthanasia.
Leo, who's joining us from
Hello everybody, I'm Leonardo Guidi, 6th year medical student from the Italian course, and my main field of study is anesthesia and intensive care, as I've been an intern at our ICU in San Raffaele for almost a year, and now I'm in Sweden for a placement also in anesthesia intensive care at Sahlgrenska University Hospital in Gothenburg, and I'm really happy to be one of the 5 hosts of this season Journal Club, and we will have some sessions about anesthesia and intensive care related topics, and I'm very happy to do this because since I know anesthesia is kind of left off from our course of study until the end, so I hope that some of our presentations that will be in the future can get some of you interested in intensive care as well. So then we have Matteo, I think he's there right now.
Hi to everybody, I'm Matteo, I'm intern in neurology department, and my thesis will be on neuroimaging in dementia, and I would like you will enjoy this journal club and be curious, make questions, and enjoy.
Finally, I'm Pietro. I'm the host for tonight, and I will do my thesis in immunology. And that's basically it. Also in the 6th year of medical school. Just a few things. We want to encourage the Journal Club because for us it's an opportunity to be curious about things that maybe in class we all found boring or we forgot. And they will probably be easier to remember because we ourselves are going to talk about them. And the other thing is we wanted to encourage the Journal Club to give agency to students, and we're not really used to organizing and be sort of entrepreneurial. So this is one of the ways that all of us, not only us hosts, but even people who will present in the future meetings, is a way to have some agency. If you want to ask a question, you can use the funzione manina. I don't know how to say it in English.
Raise your hand.
Raise your hand, the function on Teams, and I hope we'll notice it. But so Eva, here you go.
Okay.
And also we will have after Eva's presentation, we will have a session for Q&A. So of course I mean, if you have really imminent questions, just raise your hand and ask. But if you can keep them till the end of the presentation, Eva will answer all of them.
Yeah, I will try to answer all
Okay.
of them.
So good luck, Eva. Enjoy.
Thank you and welcome everyone. Okay, so today we will discuss, we will revise maybe a little bit what it is a bicuspid aortic valve, and also its possible treatment, and also the new approaches for the near future. Okay, so I will start with a question. Okay. I will start with a question. You can try and answer it. Don't be scared. I will not give you a grade. This is not a class, so you can answer honestly. How would you define a bicuspid aortic valve? Anna here is making some.
A valve with 2 leaflets.
Yes, exactly. So in the main way, we can describe, so on the right, you see a normal tricuspid aortic valve, and on the left, you see a bicuspid aortic valve, okay? In reality, the situation is much more different, okay? There are different shadows and different presentations of this bicuspid aortic valve. The Sievers classification classifies bicuspid aortic valve. So Sievers type 1, you see there are only 2 cusps, okay? This is a view with an angio CT scan. The Sievers type 1, you actually see that there are 3 leaflets, okay, but 2 of them are fused, okay? So there is a small raphe, okay, that connects 2 leaflets, okay? And it's the most common type of bicuspid aortic valve. Instead, Sievers type 2 has actually 2 raphe fused, so actually has only 1 functional leaflet opening. Of course, as you can imagine, type 2 and type 0 are the ones that have the most consequences, even though type 1 is the most common, okay? It is actually bicuspid aortic valve, the most common congenital cardiac abnormality, and affects 1 to 2% of the general population. So as you saw in the previous pictures, it is composed of 2 abnormal leaflets, unequal in size, and it is due to an inadequate production of fibrillin 1 during valvulogenesis. So we could have 2 onsets of symptomatology, okay? You can have onset of symptoms in very young children or newborns, okay, usually present with a very severe stenosis of the valve, so a valve that is completely not functional. Generally, it is not treated with substitution of the valve at this age, okay, because children tend to be very young. So usually just use a balloon to enlarge the valve and make it function it a little bit better, okay, until at a much older age you can do a surgical treatment. The other age in which it typically present, it's a little bit more in the elderly population, even if it's a little broad as a term, because it actually also arises when patients are 50 to 70 years old, so not really elderly, but much older than younger children. And is actually one of the most common causes of stenosis of the aortic valve, a bicuspid valve, okay? So usually in the elderly population, what we see are these type of complications, okay? So we see valvular complications, such as a stenosis of the aortic valve, which is a valve that is not complete, it's not the adequate size, but it's a little bit shorter, so it's a little bit smaller, or valve insufficiency, okay? So valve not closing in the proper way, and actually, or a little bit bigger, okay, than is what it should be. The third option is endocarditis, so an infection of the valve, which can have very serious complication later on, so in the long-term consequences. We can also have vascular complications, such as aortic aneurysm, dissection of the aorta, or rupture of the aorta, or rupture of the annulus. And also coarctation. You can see it's in gray because it's not really a complication, but it's more of a pathology that is related to bicuspid valve. So it usually happens together. So not really a complication, but for sake of completeness, we just wanted to include it. Symptoms and diagnosis, okay? We will focus on stenosis of the aortic valve because, well, it's one of the most common presentation of the bicuspid aortic valve. You can also not have symptoms for a very long time, but it usually gets symptomatic eventually, especially in the more elderly population. So what you will have are symptoms of dyspnea, so shortness of breath. So when, for example, doing some kind of exercise, you will get some, like, literally your breath is short. You cannot get hair, like you're grasping hair. And this is defined with a NIA classification that defines the dyspnea to be very non-severe, so classification 1, to very severe, even at rest. Patients don't get enough air even at rest. Syncope, so you just point out blackout, or exertional angina, so chest pain or chest oppression. And these are the main symptoms that usually present with stenosis of the aortic valve. And the diagnosis can be done with the semiotics is actually very peculiar, okay? Once you hear it, I think you will never forget it because it's a very typical sound that you hear it. It's also very strong if the stenosis is very severe. Once you hear it, you will never forget it. Secondly, with an echocardiogram, okay, so you can do a transthoracic one or a transesophageal one. If with a transthoracic, you will not get enough information. And second line diagnosis is angio CT scan. Of course, it's also in gray because it's not really a first line approach for diagnosis for the diagnosis of this valvulopathy. Now, what we'll see is actually an example of an echocardiogram, okay? So the first one on the left, the one that is playing right now, it's called the parasternal long axis view, okay? You cannot diagnose a bicuspid aortic valve just looking at this echocardiogram, but you can actually notice, okay, I don't know if you can see, no, I don't think you can see my little hand moving, but you can see in this image, you see the left atrium, okay, the left ventricle and the aortic valve, which is not open correctly. It's that little thing, the little white dot moving, okay? Okay, so in this case, it's not opening completely well, okay, but you cannot diagnose a bicuspid aortic valve just looking at this view. What you need is actually this other view on the right, okay? In this case, you can actually notice that the valve, it does not form a trileaflet, okay, but it just forms an oval, okay? You see it here in the center, okay, that when it opens, it's oval, okay? So this is a bicuspid aortic valve seen with a parasternal short axis view, okay? So this is the first main thing that any cardiologist usually can use to diagnose it firsthand. Of course, usually then you refer it to a specialist, but in almost every office of a cardiologist you will find is an echo that is able to diagnose it. Then the second important thing to do is assess severity. Of course, you can treat bicuspid valve if you have symptoms, okay, that will not go away with the medical treatment, so with drugs. But usually you treat it when you have a severe aortic stenosis, okay? And severity is assessed by looking at these three values. So so the aortic velocity, okay? If you remember physics from high school, you will remember that if you decrease the radius, okay, of a tube, okay, in which fluid passes through, you actually see that it goes much faster. And I know if you have a garden at home and you actually like water the plant, and you see that if you squeeze it, it goes much faster. Okay, this is the same principle. Same as gradient, okay, gradient increases transvalvularly if there is a stenosis, and of course the aortic valve area will decrease because it's a stenotic area. What you actually can notice in some patients is that they will have a decreased function of the left ventricle. This usually happens in this case that you notice in the slide, the low flow, low gradient valve. Okay, so a patient having a dysfunction of the left ventricle will have a low gradient. So it doesn't, there is not such an increasing gradient because the flow is very low, okay, because the left ventricle is not pumping enough blood, okay? But usually in normal patients, you actually see a normal ejection fraction because the heart remodels, okay, to adapt this very strong resistance against their pumping function. So after assessing severity, if it is severe, the first line treatment is surgery, okay, especially because the patients tend to be young, okay, as I said before, either children or young adults or adult age from 50 to 70. So you will have to do some kind of surgery. You cannot do any other treatment, okay? You see in this little sketch, what you actually do, you either substitute the valve, or you substitute the valve and the ascending aorta, or them together, okay? So you can do them together, you can do only the valve. Usually, eventually, patient will also need some kind of treatment on the aorta, okay? This is why in younger patients, you tend to prefer surgery and just substitute the both of them. But there is always a but. In patients that have comorbidities or have a very high risk, operative risk, okay, which is calculated using the STS, or have very compromised major organ systems such as lungs or kidneys or any other major comorbidity, doing a surgery option is not feasible. Okay, you can notice here that the chest is completely opened. The little tubes that you see is actually an external circulation, because you have to stop the heart to do this operation. So you need an extracorporeal circulation in order to support the body, but by also having the heart stopped. Okay, so this is a very high burden surgery. So in patients that cannot do this type of surgery, you can actually try and do the TAVI or TAVR. Okay, so it's transcatheter aortic valve replacement or implantation. In base, you see R or I at the end. It's the same, which is much less invasive. But up until now, guidelines actually excluded for patients with bicuspid aortic valve. And the reasons why, okay, here you would actually, the reasons why it is excluded, we will see it shortly. Before I want to show you what the actually TAVI is, okay? So you actually see here, okay, you get access from the femoral artery, okay? You see here this iliac artery, you go up, 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 okay, until you are in the aortic arch and finally in the left ventricle. So this is a guide wire, okay, through which you can insert all of your devices in order to do this kind of procedure. First, you do, not in all patients, but in most of the patients, you actually do a valvuloplasty. So you actually do a balloon that opens the valve a little bit, okay? And then, okay, so to open it a little bit, okay? And then you carry on the devices in order to implant the prosthesis. Now we will see it. Okay, so here it comes, and you actually swim up against the blood flow. And then you go into the aortic arch, finally into the valve, deploy the valve. Okay, this is actually a balloon expandable, so you actually see that there will be a balloon expanded valve. There are also self-expandable valves, which are a little bit different from this one. And now we can actually see how the valve works. Okay, it turns a little bit, and it will show you the little valve opening. It's actually very cute if you see it live. Okay, because of course you won't see everything. You will just see the little valve opening. This is just in a cath lab, so you will just see the little valve opening. Okay, so now in order to plan the procedure, you have to do the echocardiogram that we discussed before, and an angio-CT scan. With angio-CT scan, you assess the vessels, so the aorta, okay, and the valve, of course, because you have to pass through the aorta, so you have to assess if it's feasible to do so. And then you calculate the visual basal ring, which is this green line here, okay, and you calculate the size of the prosthesis that you want to implant. This is actually very important, because getting the right prosthesis matched to the size of the virtual basal ring is what ensures an optimal success of the implantation. Because if you have a too little valve, of course it will not match, because it will not open correctly. And if you have a too big one, you can actually have very negative complications. Then you do the procedure. What we saw before was the transfemoral axis. There are other two axes, but they're much more rare than the transfemoral one. And then afterwards, you check the implantation success using the echocardiography and/or angiography. So you assess the gradient, this is one that we saw before, and the paravalvular leaks. Okay, paravalvular leaks are little leaks because maybe the valve didn't implant in the correct way. So around the valve, you see a little bit jets of blood, okay, passing through. It means that the valve didn't implant in the correct way, or maybe it was really much calcific, and so you couldn't really open it correctly, so a little bit of blood still passes around it. Okay, so this is why it is pivotal in order to choose the correct size, because if you choose a too little one, you will have a really important paravalvular leak, okay, which is not a successful operation. And these are the consequences. Okay, the most common ones are bleeding and pacemaker implantation. I actually see many of them in a department. Ictus and embolization, you see some of them. I have never seen aortic or ventricular rupture. Of course, I've been in the department 8 months, so not a very long time. But in 8 months, I've never seen one, because it means that you have to open the chest of the patient. So it's a very complicated complication. Okay, so we discussed what are the problems of TAVI in bicuspid aortic valve. Usually these patients have a very big annulus, and it's usually not round, but a more elliptical shape. And also you have very calcified valve. Okay, so if you have elliptical shape and the prosthesis is round, you can understand that it's not a match. Okay, you will have those the ones that I said before, the paravalvular leak. Okay, this is due to the symmetric valve expansion into the anatomical place. Okay, because of course the anatomy is not completely matchable to the prosthesis. So what we actually did was this, the Lira plane. Okay. I will ask you a question if someone is still paying attention. So have you ever heard of the Lira plane? I don't know if someone is still paying attention to what I'm saying. I don't know if you ever heard it. I'm seeing a lot of no here in front of me. Okay, so it's actually a better way, a possible new method of sizing this valve, okay? Because of course, if you have elliptical, okay, or extremely large ones, it means that you maybe not even have the prosthesis to match these really big valves, okay? So the Lira plane, okay, it's actually, I'm sorry, but this is my sketch. I couldn't find a better picture on internet, so this is my sketch. You see, VBR is the virtual basal ring, okay, where we calculated before the size of the prosthesis. The Lira plane, okay, is the level of implantation at the raphe, okay? So we actually implanted a little bit higher, okay, in order to maybe have a more round anatomy, okay, a little bit more calcification, which is actually sometimes better in order to have a correct anchoring of the valve, and plus, okay, so you risk having and also it's a little bit, of course, smaller, okay, so you can actually have a matching prosthesis to implant. So this is the new method that they're actually developing right now in this hospital. We do not know yet, okay, if the procedural outcomes are better with this method or not. This is what one of the things that we have to answer about this new approach. We hopefully, as I said before, right now, bicuspid aortic valve are actually, according to guidelines, one of the exclusion criteria in order to do the catheter, so the percutaneous approach. So we hope that this new approach, it will become an official possibility for patients that cannot undergo open heart surgery, because remember that it's always the first line approach for this kind of pathology. So this slide concludes my very long monologue. I hope everybody enjoyed it, okay? And I hope you are still paying attention to it. And I will pass back. If you have any question, now is the time. Okay, I have one here in the room.
Yes, I would like to ask if you can repeat the Lira plane.
The Lira plane, yes. Okay. Okay, so here, okay, the AVA, okay, is the area of the aortic valve, okay, is where you actually see if there is a stenosis of the aortic valve. It's the values that we saw before had to be smaller than 1 centimeter square in order to diagnose a severe stenosis of the aortic valve. The virtual basal ring is actually the aortic annulus, okay, so at the base of the leaflets, okay, you calculate it there. In normal patient with the tricuspid valve, you calculate it there. Okay, the Lira plane is a little bit higher. Okay, it's between this the area, okay, at the end of the leaflets and the virtual basal ring, so the aortic annulus. It's a level in between that usually anatomically is more round. Okay, so you actually can have a matching prosthesis, and so a lower risk of having paravalvular leaks, and also you can have a matching prosthesis because as of a few years ago, they actually undersized the prosthesis in this patient, which eventually led to a higher rate of leaks, which in the long-term consequences can mean developing insufficiency of the valve. So you treat one problem, but you create another one. Okay. Yes, absolutely. You only use it for the bicuspid aortic valve, and it's a new method to sizing the prosthesis. So to get a better matching between the prosthesis that you want to implant and the patient's anatomy, because every anatomy is different. So you always have to check the angio CT scan, the one that we saw at the beginning. Okay, when I explained the Sievers classification. Okay, so here, okay, you look at the angio CT scan, okay, and you have to match it perfectly. It's actually a little bit hard to get at the beginning because you have to do a lot of like different planes and angles in order to get this number right, but it's the one that actually ensures most of the success of the implantation. Of course, if the operator is well trained. Of course, if the operator is not well trained, you have other type of complications, not only related to the mismatch between the prosthesis and the patient.
Any other future cardiac surgeon or interventional radiologist that wants to
Cardiologist.
interventional cardiologist that wants to ask a question?
If you want to ask a question, just
Even
open
maybe
your microphone.
from earlier years, so that maybe you have some questions about something that wasn't clear. I have questions. Oh, we have a question.
We have a question from home. No, went back in shy mode.
I would like to add something if it's possible. Can you hear me?
Yes, please.
Okay.
No, not.
Can I tell something? Okay, now?
Okay, now we can hear you.
Okay. Okay. I think it's just
Ok,
mi sa che ci stiamo sovrapponendo.
There are
adesso ci sentite?
Paci Gabriele and Costa Paolo. Costa Paolo, please start and then.
Okay, yes. For the aortic valve replacement, which are the indications for TAVI compared to the surgical one? Because I know TAVI is much less invasive, but it has also been practiced for a lot fewer years than SAVI. So what's the situation now?
Okay, so usually, first of all, you check the age. Okay, in general setting, under the age of 75, you prefer to do a surgery. This is because the bioprosthesis that you implant doing TAVI usually last up to 10 years. Okay, so if you implant a bioprosthesis with TAVI in a patient that is 65, in 10 years you will have to redo it. Okay, so there is not much point of it. So usually after 75 years of age, you prefer to do the TAVI, and under 75, the surgery. It also depends on the comorbidities of the patient. You usually actually use this STS, short-term risk. Okay, it's a little bit long to calculate it, but it actually assess the perioperative risk, and based on this, you can actually decide if for the patient is better to do TAVI or if for the patient is better to do the surgical approach. You will check the comorbidities, major organ system, also the anatomy. Okay, there is a case in which you cannot do the surgical approach, which is the porcelain aorta. So if the aorta is very calcific, you tend to prefer to do a TAVI approach instead of a surgical approach. So you actually have to calculate a lot of different factors. Usually, when you are in doubt or when the patient is young, you do a multidisciplinary team. Okay, so usually cardiosurgeon and anesthesiologist and cardiologist and specialist of the echocardiogram usually meet together and discuss if for the patient is better to do a percutaneous approach or a surgical approach, okay? Because you have to consider that the surgical approach is very high burden, but the percutaneous approach has a limited short time in which you will have an effect. Usually in 10 years, you have to redo it.
We have another question though from the online crowd. Paci Gabriele.
Would like to add something. We have to remember that one of the reasons why the TAVI, the transcutaneous replacement is actually a contraindication for the treatment of the bicuspid aortic disease. It's because it's not only a disease or only about disease. It's we have to remember that we have a very high prevalence of aortic coarctation in those patients, and it's an high prevalence of a disease of the ascendant aorta as well. So if we choose the transcutaneous method, which is actually like an off-label method of treatment only for those which are not suitable for surgical intervention, we lose a really important part of the decision of which kind of surgical treatment we have to do, because when the surgeon opens the chest and goes to the aorta, it usually goes to feel which kind of consistency the ascendant aorta has. Because we have a problem in hemodynamics. We have a turbulent flow, which causes more stress on the ascendant aorta. So we have a mechanical reason for an higher prevalence of aortic aneurysm. But we have also reasons due to the alteration of the tissue. So if we go to transcutaneous, we will not go through this decisional process, and it's a great loss, especially in younger patients. So it will probably won't be a pair option against the surgical replacement.
Yes.
Yeah, that was
Always
gonna be
remember the surgical approach is the first line. Okay, if the patient doesn't have comorbidities or if the patient is not 85 years old, usually you prefer doing the surgical approach because you can substitute both the aorta and the aortic valve and the ascending aorta together.
And I had another question actually. One of which was this: when you do you said that often you do the valvuloplasty before the implantation.
Yes.
You just get rid of the whole valve.
No, the valvuloplasty is just a balloon inserting into the valve and opening it.
And doesn't that cause problems? Like maybe it displaces in the future? Or...
Yes, you usually do it in emergency setting, or if just to like put a pause on the surgery, just to wait a little bit longer. Usually in very young children, in which with a valvuloplasty you can gain a little bit a few years. Okay, so the child can grow a little bit and the heart can grow a little bit, and you can substitute it later on. Okay, so you actually do it just to press pause. It's not a long-term solution.
Okay. We had some questions.
You said that among the other complications of the bicuspid aortic valve, there is also aortic insufficiency, if I'm not mistaken, right?
Mm-hmm.
There is aortic. So if, for instance, for the mitral valve, we can use the mitral in patients with aortic insufficiency, it will be possible, or the flow out of the left ventricle is too strong and will.
It's too strong. If you consider the gradient.
Maybe they haven't heard the question is, if correct me if I'm wrong, if you can use a sort of what would be a mitral clip on the aorta. Okay.
It was actually one of the first questions that I had when I started in the department. Unfortunately, no, because the gradient, the pressure is way too strong at the level of the aorta, of the aortic valve. So you actually risk the embolization of these devices and cause massive problems. So unfortunately, the clip option is not an option for the aortic valve.
I would ask if the stenosis of the valve, the bicuspid valve, is something that gets worse with time or stabilized.
Okay, so if the question is if the stenosis of the aortic valve worsens with time or it's stable.
No, usually it worsens, especially with age. Okay, you don't always diagnose a severe stenosis in patients on the first visit that you do with a patient. Usually diagnose it when it's mild or moderate, and then you do a follow-up. Okay, you actually do surgery in mild or moderate only if the patient is severely symptomatic and the symptoms not improved after medical therapy. Okay, so usually you can diagnose it in mild, and then in a few years you see that it develops and goes to mild, to moderate, and to severe eventually. So this is why in patients with these kinds of diseases, you actually do a very strict follow-up in order to follow the patient and check how the valvulopathy is evolving in the years.
Okay. Any other question from home or doubt or question about the journal club?
Yeah, so also questions about the journal club. I wondered. Today we met at 6, but maybe I don't know if it's better for everybody if we meet a little bit later. So I don't know, around 6:30ish.
Yeah, we're gonna make
an official communication
yeah.
on all the different channels in which we communicate.
Okay, so for our future, we will know that if we have a very old and very sick patient, we can recur. Maybe recur to TAVI in case.
We are doing it right now, but it's an off-label approach. So maybe in the future it will be on the guidelines. We don't know yet. I'm doing my thesis on this topic here, so
we'll let you know in July
exactly
when this update in the
if in July you will
European
follow my
ESC cardio update from Eva Bijlsma guidelines. So thank you very much for the attention. Thank you, Eva, for the presentation.
Thank you if you followed for all this time.
Thank you if you followed. And we wanted to thank Professor Manfredi, who's our warrant and supervisor. He follows every class, he follows every presentation very eagerly. So thank you very much, Professor. And
clap hands.
no,
solo battendo le mani.
Okay, so we will see you next Monday. I hope to see.
If nobody has to say anything or has questions about the journal club, then yes, we will see you next Monday.
Say that, of course, if you wish to present your own project or paper, we are really glad if you do it. So just send an email to, I think we have an official mail right now, right? Or not?
We have an Instagram page, but
okay, we have an Instagram page, so you can write on Instagram. I think there's my mail below one of the posts on the Instagram page. So you can write an email to me or any of us. Of course, the mails are here in the meeting, so you can find them quite easily. And if you wish to do that, we will put you in the future calendar. And thank you again, Eva.
I think Professor Manfredi is trying to speak.
Oh, Professor, please.
Not at all, not at all. Quite very interesting. Thank you very much.
Okay, thank you.
Thank you. If you see us in the hospital or in the university, you can ask any of us 5. Okay, maybe you won't meet Leo in the hospital, but
not yet. Not for now. But yes, and of course, also for the next presentations, if there are like younger students that maybe feel like they have some really basic questions they are shy to ask, just be like that and go straight forward and just ask them, of course. Don't shy in any sense. This is a really democratic place in which you can ask everything and talk about everything you wish, of course, science related.
All right. Thank you, everybody. Thank you. See you next time. Buon appetito.
Big kiss.